Good afternoon. I'm George Plotkin. I see patients with a variety of movement disorders, and Dr. Wu is my partner. And we see quite literally thousands of people with different movements. One of the most common movements, probably the most common movement that's of interest to me, is essential tremor. Essential tremor, just to give you some background, is a relatively old idea, unlike Parkinson's, which came into its own in 1817, basically 200 years ago. We now have essential tremor, which has 26 references in Genesis. Tremor means to shake in Greek, pretty straightforward. And the ancients had a good idea of what tremor was. They said tremor was something that you saw in the infirmed, the elderly, and the weak. So if you showed up before God and he talked to you, you tended to shake. That was one of those things that they noticed. That's why there's a lot of that in Genesis. Tremor, however, is a very interesting phenomenon. Why should the system demonstrate shaking at all? Well, it turns out that normally when you try to move a muscle, any of you work out, or you can tell I don't. But one of the things that's interesting about working out is you don't start cold, you limber up. What you're doing is mobilizing calcium from the surface of the sarcomeres, the motor fibers in your muscle system. What that accomplishes is it reduces the viscosity or stiffness of muscle by 300%. What tremor is doing in a non-symptomatic individual is it's firing your muscles all the time randomly. Little fibers are firing all the time. If I put a tremor measuring device on the back of your hand and have you put your hand out, even though you have no tremor, you will have this little bumpy stuff going on. And everybody says, oh, that's noise. It's not noise. It's your muscle keeping limber. It's why you're stiff in the morning when you get up. And so the business of tremor is a pathologic extension of what's a normal phenomenon in the nervous system. This is the Waco Kid from Blazing Saddles. Now he's doing something that we see a lot in, sometime this year, guys. It's something we see a lot in essential tremor, which is treating with alcohol, because alcohol affects the chloride channel in the brainstem, which damps out the oscillation. So he's also, notice he's drinking, his right hand is stable, and that's the hand he's using to drink with. I don't know if you can hear this because it's terrible volume. It's full up.
Maybe a couple of years ago I could have shown you something, but today, look at that.
Okay, so the point is, this is actually an important take-home message. Which is that essential tremor can affect the head, it can affect the limbs, one or the other. It can affect at any time in life. But if it doesn't affect something that you need, then it's not going to be something you complain about. So for instance, the rate at which people complain of essential tremor in the real world it varies over 10,000-fold. If you are a dirt farmer in sub-Saharan Africa and you eat with your right hand and you have left-handed tremor, you are never going to come to a doctor. On the other hand, if you're in Sweden and you have a dominant hand tremor and you like writing long, thoughtful letters to your aunt on your mother's side, you are going to be in the doctor's office looking for some therapy because your hand shakes. And so we see a variation of 10,000-fold at least. It is the most common disorder. It's associated with rhythmic shaking around a joint. It's not like this. It's rhythmic and uniaxial. When it's multiaxial, it's something else. It can be seen in a lot of different parts of the body, and so we can go through that. It can occur with task. So some people will complain that they can do everything but hold a spoon. And we have weighted spoons which can help them. In other people, it only occurs when they write. And sometimes we can work with that with therapies that are both interventional, either Botox or DBS. And some people only have it when they hold their hand straight out from their body, and they'll say, oh, it shakes like this. So each person's a little different. In fact, within a single family, you could see many different flavors. This is the anatomic distribution. Most of the time it's the hands, which is on the left there. And then it goes to the head, sometimes the voice. Katharine Hepburn had classic whole body tremor by the time she died. Her mother had had essential tremor, and she inherited it from her mother, and it slowly progressed. If you like old Katharine Hepburn movies, look at Little Women, where she plays Jo, and she shows one of her sisters how to pretend she's scared and says, you just put your hands out and they shake. And that's not acting. That's her. So again, unilateral, often focal at initiation, one hand. It can go like that for years. If it starts in a leg, I'm a little more interested that it might be something else. If it happens suddenly, I'm bothered. I'd like to know what else is going on, because that may be another disorder. If you're on Reglan because you have GI problems or metoclopramide, then I would be concerned it could be a Parkinson's syndrome due to the medication. Amiodarone or cortisone also can cause a Parkinson or tremor-like syndrome. Depakote, lithium, Prozac. In fact, just about every medicine in the PDR can cause tremor. So the lawyers have a field day. Everything causes tremor. Here's an example, and I'm hoping maybe this one will play. Maybe. Or not. So let's go back to this and try it again. So it looks like tremor. She puts the hand out, it shakes, but when she puts it back down, it keeps shaking. So she's got a tremor at rest and a tremor with action. She's also had a headache for the last few months. There's no family history of tremor. And this is what was found. Let me orient you. Maybe I can make this work. This is the front of the head and the back of the head. These are the sinuses. This is the nose. These are the angles where the ears come out. And this is the brain tumor. This is a, which one? It's an epidermoid. This is an epidermoid, fairly rare, but when they grow, they can become symptomatic and cause a tremor. So in her case, treating her for tremor would have been a mistake. It's one of the reasons that you'll wonder, why do doctors order so many damn tests? It's because we're not stupid, and we know that we don't know. So I've learned over the years to be very humble and order the MRI. Everybody with essential tremor gets one imaging study, at least. If I find something abnormal, I may have to order something else, but the bottom line is I've seen things like this more than once in my life, and I don't want to send somebody out and say, oh, you just have tremor, have a nice day, and then have them in on the autopsy table. It's embarrassing. So who's affected? It's 10 to 20 times more common than Parkinson's. It's probably even more. Parkinson's affects 2% of people over the age of 60, maybe more. Essential tremor affects up to 9% of the population over the age of 60. It can occur at any time, and it is a genetic disorder. For the most part, if a parent has it, a child has a 50% chance of having it. What's interesting about it is that even when people say, well, there's no one in my family who has tremor, Elan Lewis at Columbia did a beautiful study where he flew in on a grant, patients, family members who they said didn't have tremor, and they did have tremor. So often we learn a great deal by looking at the family. Age of onset, anytime. I've had families in my office, 3 generations, where grandma has got a little bit of tremor, dad has a little more, and there's a 9-year-old there shaking like a leaf. It can go the other way. It doesn't necessarily anticipate. But the parts responsible, it varies all over the board. There is no way to predict who's going to have bad tremor or good tremor. Disability, to call it benign essential tremor is an insult. There's nothing benign about essential tremor. It interferes with people. 60% of people who are diagnosed with essential tremor go on to not take advances in their careers. They often retire early. They change careers and they withdraw from society because it's embarrassing, as they'll tell you, to eat in public, drink in public. They don't like tossing the salad at the food bar, you know, at Luby's. And so they're socially isolated. And so the treatment for this has become really an important point of what we try to do. And I'll skip that. It basically is going to tell you it's a common disorder. There are no really genetic tests for it. We can exclude Parkinson's. That's one of the things that's helpful. We have something called a DAT scan, which Dr. Wu already showed you, so that we can take somebody who we're questioning essential tremor, and we are not entirely sure. We can do the DAT scan. If the DAT scan is normal, it's less likely that it's Parkinson's, and it's more likely that it is tremor. And we can do a batch of tests in the office, very simple ones. Pouring water from one cup to another, drawing a spiral called Archimedes spiral, and doing tasks. If a person comes in the office and says, I only have tremor when I do X, you don't start to do Y. You do X and see what it does. You may want to do Y later, but focus on what the patient's complaining of. It's important to listen to the patient. I know that's a new idea, but, you know. We don't know what causes it, but I can tell you it is. I can actually build a circuit. I'm an engineer of sorts, and I dabble in that. And I can build you an electric circuit that does precisely what the nervous system does, which is oscillate. It's very simple. The triangle of Mollaret, which is a structure that goes from the inferior cerebellar peduncle all the way up to the thalamus and back down to the dentate nucleus in the cerebellum. It's just a big triangle, the triangle of Mollaret. Any lesion in that region causes shaking, and it can be of any flavor. And we never find the lesions. We image people, we don't see the lesions typically in essential tremor, but we know that there's something wrong with the timing circuit, which is kind of interesting. So other causes. If any of you have ever been on I-20 and gotten cut off by an 18-wheeler on a wet day, you will develop tremor. You may also develop bladder control issues. I certainly have seen this more than once. It is an important thing. That's called enhanced physiologic tremor. It's the normal firing of these nerves that allows you to have nice, loose, spontaneous movement where they become synchronized. A fellow who did the work was a guy named Logigan back in the 90s, and he did a beautiful job demonstrating that this was different than the oscillation we see in essential tremor. The only therapy that cures enhanced physiologic tremor is dying. I don't recommend it. Medication-induced tremor, again, there is stuff that you get over the counter. We have more people come in with weird tremors who are taking herbals. There are a lot of interesting things out there that will make you shake like a leaf. Don't necessarily make you feel any better, but you will shake. And then trauma. Trauma to the head can cause shaking, not Parkinsonian and not essential tremor. It's something else. And thyroid, of course. Then we get interesting things like this. Come on. This is somebody who has a perfectly normal exam sitting down. Very nice person who was told he had a psychiatric illness. He was about the 6th or 7th person I had seen with this. Totally normal exam sitting down. They get up, they hunch down, and they walk around like this. And everybody says they're crazy and puts them in the psych unit till behavioral health until, I don't know what they call it now, some sort of, better for your brain thing. And then you go over and say, wait a minute, no, they just have orthostatic tremor. The oscillations in the legs are from the central system, but when they oscillate like this, you can't get your joint position sensed straight, and so the complaint is, when I stand at the counter at the Walmart, I want to fall down, but as long as I'm walking, I'm fine. And in fact, I can show you, here is a needle stuck in the patient's muscles in their leg, in the anterior muscle and the posterior muscle of the calf of the leg. And when they're sitting down, there's no activity. When they stand up, these things are firing at 14 cycles per second. You can't do that volitionally. Impossible. This is an oscillation from the central nervous system, and the chief complaint is they go boom when they're standing still. So they always have to move. They look very uncomfortable. So anyway, that's another type of thing. Again, we can have lots of other things that cause shaking. I'm not going to worry about those. And every drug, like I said, every drug causes tremor. So is it essential tremor or is it Parkinson's? Sometimes you can have both. They're both common disorders. When Dana first described when he first described essential tremor as a genetic disorder in 1857, he had identified several families. Gower in England had been observing families, and the question came to Gower, who was contemporary, was that I have these families who have Parkinson's and essential tremor. What do you make of that? And his comment was, two common diseases, what do you want? You multiply the probability of one common disease against another, you're going to have some people who just hit the jackpot, you know? So absence of stiffness, absence of shuffling gait, so the trap of Parkinson's, tremor at rest, rigidity, akinesia, postural instability. If the trap isn't there, it's not likely to be Parkinson's, it's more likely to be essential. Treatments, we want to reduce or damp out the tremor, so mechanical treatments, weighted utensils, or utensils that actually counteract the movement. So Lift Pulse, LIFTPULSE, has come out with spoons that have gyros in them. And you can actually use these things in public and you won't shake your food. Medications, beta blockers, if you have asthma, you're going to wheeze, or respiratory arrest in some cases. The other thing that can happen is your sugars can go crazy because if you have diabetes, the propranolol and the other drugs in that family can block your ability to generate sugar or get what's called a Somogyi reaction, and you could potentially die. So it's not the ideal drug for everyone. These are the first-line drugs, though, so we recommend these to people. The next family of drugs that we recommend are second-line drugs, are anticonvulsants. The first one, primidone, has been around for 70 years and works very well in 60% of patients. One patient told me that 60% of patients get 60% benefit. That was his opinion. And he was a pretty bright guy. He was a medical doctor. Gabapentin doesn't really do much, but some people seem to believe that they will keep promoting gabapentin. Generally just makes your legs swell and you feel tired and your gut aches. Topiramate in controlled trials, there were two major trials. One worked, the other did not. So it's really a question. I've experienced some patients have complete response to Topamax and other patients don't. The caveat is that it can cause kidney stones, and so if you have a history of kidney stones, we don't recommend it. Benzodiazepines work on the same receptor in the brain that alcohol does. So you have to be very careful. Clonazepam, which is popular with primary doctors, can accumulate in your body and cause lethargy and confusion and car accidents. Diazepam's a horrible drug, and I don't recommend it. And Xanax works too quickly and causes people to be high as a kite, so we generally don't use it very much. At least I don't. And alcohol causes rebound tremor. It can work for about 2 hours, and then you're shakier than you ever were. Eugene ONeill, the playwright, died of alcohol poisoning. Essential tremor ran in his family, or one of the tremor disorders. And unfortunately, as he said in his last writings, born in a hotel room and died in a hotel room. And he died of alcohol poisoning. In some people, writer's cramp, which is a form of tremor, where it's specific to a task. We have people who get tremor with dart throwing, golfing. It's called the yips. It's a type of dystonic tremor. Or in the case of pianists and violinists, they can have hand tremors that are very specific to a particular position they take on the instrument. Those can respond to botulinum toxin injections. It's a hard thing to do. We do them. Sometimes they work very well, sometimes they don't. It's a little bit of a shooting match. It's better, as it says here, for the postural tremors. And again, dependent upon physician expertise. In other words, if somebody's doing them all the time, they're likely to have better luck than somebody who's seen one a year. So you have to think about who's treating it. There's been no evidence that Zen, behavioral therapies, chiropractic, or a variety of other things have had any benefit for tremor. The thing that we have known that helps tremor has been DBS. Let me see, let me close this out and show you some things. Where is it? Let me show you a couple of things. This is an interesting display. It's worth seeing.
So To conceal the identity of our next presenter has called for a security operation of truly royal proportions. And why not? Gertrude Stein might have said, a star is a star is a star. But to me, this is a star. Ladies and gentlemen, Miss Katharine Hepburn.
This is the one and only time she was given an Academy Award. Let's pause it. This outfit that she's wearing was designed by my teacher, who was her doctor. And what you can appreciate is something called the geste antagoniste of Charcot. He designed a high collar that stopped the head from rocking back and forth, not by pressure, but just by gentle touch. So it's a self-negating of the tremor. And as a consequence, her voice is much better than it had been. She has mild head titubation, a little bit of a no-no tremor, which was her baseline. Without the collar on, it was terrifically accelerated. She's on primidone and this and beta blocker.
Thank you very, very much.
A little bit of tremor in the voice.
I am naturally deeply moved. I'm also very happy that I didn't hear anyone call out, "It's about time."
Okay. Remarkable lady. If I can make this happen. Nope, I can't. I guess I closed that. One of the interesting things is that she wanted a pantsuit because it irritated the heck out of Louis B. Mayer. Which is kind of interesting. Now, this is, no, that's not the one I want. Where is it? The static, where it go? Okay, this is not the right one. Let's do this one. Here we go. It's interesting, finally the thing they were looking for came up. That's okay. So let me show you something with DBS on off. That's not it. I lied. My favorite. But this is not essential tremor, so this doesn't count. I won't show you that one. I apologize. This is always the part where you're not expecting it to be. This is not it. When in doubt. So this is a patient who has action tremor, worse than her left hand, and she receives DBS. This is with, on the right you can see the tremor is gone. So she had a good response, and 90+% of people with DBS for essential tremor get benefit, significant benefit. Her tremor was present both with gait, and while she looks Parkinsonian, she is not. So I think that explains a little bit about what we can do by sticking a needle in somebody's brain, which is kind of interesting. Now the other patient I was going to show you is this one. So this is a gentleman who had sudden onset of tremor, sudden onset. So was diagnosed as, quotes, essential tremor. See what he's doing? This is not a disco move. This is a reverse myoclonus or negative myoclonus. I've seen this once. But it gets your attention. And what this gentleman had, he actually had some findings that are hard for you to appreciate, but they're neurologic findings that are localizable to an area called the callosum, the corpus callosum of the brain. And he had an infarct, of a very unusual infarct of the blood vessel that feeds the callosum. and it's suddenly woken up with tremor. He was told it was tremor, and then the doctor who saw him said, no, 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 you have negative myoclonus, you've had a stroke, which is again why we do what we do. This is interesting, and this will be my last thing, and then we'll be open for questions. This is Eddie Adcock. Do any of you know Eddie Adcock, the banjo player? Some of you do. He went for DBS. It wasn't here, but it's great because he's there playing his banjo during the surgery, and they adjusted the programming and location of the lead intraoperatively to maximize his ability to play. He had developed essential tremor and could not pick the banjo. And so the surgeon's behind there, and here's someone on the lower right there who's adjusting the electrode to see if they can optimize his playing style. He got very good results. But how often do you get to take a banjo into surgery? I just think that is that's a disconnect that I love it. He did very well, but they're there. None of them really great appreciators of banjo music, so I'm sure they didn't know whether or not his Gibson was playing better or worse. Mary thinks it's a little better. Anyway, I'm going to leave it at that. So to summarize, what you're looking at when you see essential tremor is, number one, it's not a disease, it's a trait. It is present in 9 to 10% of the population in your age group. So 1 in 10 people in the room has essential tremor, whether they know it or not, number one. Number two, it is not benign in the sense that it can become quite a nuisance, and if it's in a dominant part of the body that affects your ability to carry out your work, if you're vocal tremor and you're a salesperson, if you have hand tremor and you're a surgeon, you are disabled. And you better think about therapy or about changing what you do. And therapies do abound, but it's important to make sure it's not due to medications, issues with endocrine organs like diabetes or sugar, diabetes or thyroid, and to make sure it's not due to something in the brain, which is why it's a good idea to have someone look over your condition who actually knows a little bit about the nervous system.